Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today we welcome Stephen Lieberman. He's a urologist, and today's Kevin MD article is titled, "Is a PSA test right for me? A urologist answers." Stephen, welcome to the show.
Thank you, Kevin. Thanks for having me on.
So first, let's briefly share your story and journey to where you are today.
Well, I went to college in Chicago at Northwestern and then went to medical school at USC, LA County. I graduated in 1977. And then I went to Oregon. In those days, we were doing internships. I did a surgical rotating internship at OHSU. And then after going through being accepted into 4 different residencies, I decided on urology. And I was actually hired by a guy named Clarence Hodges, who wrote an article with Charles Huggins in 1941 describing the relationship between prostate cancer and testosterone, male hormone. Dr. Huggins won the Nobel Prize for that work. So Hodges was a big deal, and he was the outgoing chairman of the Department of Urology at the time. And then I went to work for Kaiser in Portland, where I worked for 31 years as a general urologist with an interest in cancer and stones and pediatrics. During that time, I developed a particular interest in PSA used for prostate cancer screening. And while I was a resident, there was no such thing as PSA. We used acid phosphatase. And half of our patients, when I was a resident, had metastatic disease or advanced disease. In fact, at the VA in Portland, we had a ward full of people receiving IV stolfosterol. Well, when PSA came around in the mid-'80s, I had been working at Kaiser for probably 3 or 4 years, and we started using PSA, and we noted a dramatic decrease in the number of people presenting with metastatic disease because they were being screened and treated. And the number of radical prostatectomies I did during my residency was like 2 or 3. And by the time PSA was around, that really ramped up. And we noted, I was doing like 2 radical prostates a week. And we noted a decrease in the number of patients not only presenting with metastatic disease, but the number of patients with metastatic disease. So incidence of prevalence went way down from about 50% to about 10%. Well, along with that came an increase in the number of patients treated for prostate cancer who didn't necessarily need treatment, because we couldn't tell the difference between indolent and clinically significant disease. And that arose from that. There came this controversy after the U.S. Preventive Task Force came out with their level D recommendation, recommending against using PSA as a screening test. So I was a very aggressive proponent of screening using PSA, because I thought, well, even though we can't tell the difference between indolent and metastatic or advanced disease, we did know that the Gleason score was fairly predictive in who was going to have aggressive and who we could treat, who was a good candidate for treatment, that being namely surgery or radiation.
Sure.
And so the Gleason score was very helpful at that time. So I'd go to grand rounds and I'd give these lectures and talk about the Gleason scoring system, and I'd talk about how we can minimize the complications from both biopsies and surgeries and radiation. And I never really was successful in convincing my primary care and internal medicine colleagues that they should be aggressive screenings either. And to the point where I went and saw my own internist. I said, "Are you going to do a PSA?" And she said, "I don't believe in that test."
Okay.
And I said, "Well, you realize who you're talking to." I said, "Please do a PSA." So,
Sure.
and then around the mid-'90s, one of the residents came into my office and said, "I just had another patient present with a PSA of 600. I said, "Wow, that's pretty high." And he goes, "Yeah, he's got bone pain. He's probably going to have metastatic prostate cancer." I said, "Who are these people? I mean, has he been screened? Has he been tested?" And the resident said, "No." I said, "Well, how long has he been a member of Kaiser?" He said, "Well, looks like a long time, more than 10 years." I said, "You know what? let's go back and see if we can call out these patients who present with advanced or metastatic disease. So he went back, his name is Jaffer Bashi, he's currently in practice in Salem, and he went back and found 100 consecutive patients who presented with metastatic prostate cancer. And I said, okay, great. And the PSAs were all in the hundreds. And so I said, why don't you go back and find out how many of them had health insurance 10 years prior to presenting. So we went back to like 1985, and he found out that 85 of the 100, he could actually prove that they had health insurance. I said, okay, why don't you review their charts and find out how many of them had a PSA 10 years prior to presenting? And he came back with this, I thought maybe 10%. None of them had had a PSA. None of them had had a rectal exam. And I said, oh, how many of them had a conversation, a shared decision-making conversation about the risks and benefits of having a PSA test? None of them. So since that time, there's been a dramatic evolution in the increasing specificity of PSA and increasing not only specificity, but sensitivity and specificity of a transrectal biopsy. But yet there still remains this controversy and this argument between primary care and urologists.
Your Kevin MD article's title is "A PSA Test Right for Me, a Urologist Answers." So just to give context, what's the current recommendations from the various major medical societies when it comes to prostate cancer screening?
That's a great question, because the U.S. Preventive Task Force has come out. Well, they've modified their level D recommendation to a level C recommendation. In the level D recommendation came out in 2012, and they modified the recommendation. They upgraded it to level C in 2018, based on the fact that because they were not recommending screening, there was an increased number of patients presenting with metastatic disease, and morbidity and mortality from metastatic disease, as you know, is significant and costly. And so most primary care people now go by that level C recommendation, which recommends against using PSA as a screening test. Recommends, again, no need to do a rectal exam either. And the urologists have just just revised their guideline for early detection of prostate cancer. I was a peer reviewer of that document, and both camps are recommending a shared decision-making conversation about the risks and benefits of doing prostate cancer screening. Well, I don't think we should call it screening. I think we should call it early detection.
Okay.
If a person wants to know whether or not they are at risk of having a clinically significant prostate cancer, then the first thing to do is a PSA test. And they're both, since both camps are recommending shared decision-making conversation, I can honestly tell you that doesn't happen because of time constraints and because of lack of proper information. It doesn't happen on the part of most primary care physicians. I have a lot of friends who are internists and primary care physicians, and I do consulting for this organization called MAVEN, which is Medical Advice Volunteer Expert Network, where I do urology consults for like primary care physicians in over 300 free clinics in the United States. And I can tell that they don't have the proper information or the proper knowledge to do a shared decision-making conversation about the risks and benefits of obtaining a PSA test.
Now, tell me, in an ideal world, if we do have that shared decision-making conversation with the patient, what are the risks and benefits of that PSA test that should be discussed during that conversation?
I don't think there are any risks and benefits of having an $8 blood test. If a person has the $8 blood test, I would recommend a risk assessment, and there are plenty risk assessment calculators available online. And I would first tell my primary care colleagues that there's no such thing as an abnormal or normal PSA. PSAs are like a fingerprint. Everybody has their individual PSA, and that person has an individual risk of having clinically significant or clinically insignificant prostate cancer. And you can easily obtain that information by going online to a risk calculator. And so you go to the risk calculator. The risk calculator asks you to plug in race, age, PSA, if they've done a percent-free PSA, which helps improve the specificity and sensitivity of the test. You can put the percent-free PSA in. If the percent-free PSA is less than 10%, there's a marked increased risk of having clinically significant prostate cancer. If the percent-free PSA is over 22%, there's a marked decreased risk of having clinically significant prostate cancers. So the first thing I would tell people is that there's no such thing as a normal or abnormal PSA. You have an individual PSA from which we can calculate your risk of having clinically insignificant and clinically significant prostate cancer. And so say you take a 53-year-old man who has a PSA of 4, and say it's his first PSA. He's never had a PSA before. Well, you go on his risk, if he's white, if he's had his normal rectal exam, if there's no family history, his risk is going to be of having overall prostate cancer is like 25%, but his risk of having clinically significant prostate cancer is 10%. So you tell that guy, well, I can refer you to a urologist. In the 10 years ago, the urologist would have a same kind of conversation with him over whether or not he would have a biopsy. Nowadays, we have a whole slew of things to do before you even do a biopsy that make the PSA test and the risk assessment even more accurate, more sensitive, more specific, so that we're actually reducing the number of biopsies that need to be done dramatically. And the main test I'm talking about is an MRI.
Sure.
So in Europe, in places like Sweden, the primary care people are now doing PSAs on people who want to know whether or not they're at risk for having clinically significant prostate cancer. So say that their PSA is greater than 1.5. If they're in their 40s or 50s, 1.5 would be regarded by most clinicians as normal. It's not. If a 40-year-old has a PSA of 1.5, that person has a 60% risk of having clinically significant prostate cancer sometime during their life. So those are the people that you want to really follow and monitor. So in Sweden, they do the PSA test. If it's greater than, the primary care people do the PSA test. If it's greater than 1.5, they then do what's called a Stockholm3. And this is all before the patient even sees a urologist. If the Stockholm3 is positive, the Stockholm3 is a test it's a combination of, I think, 5 protein biomarkers, and there's some genetic markers, and then they use clinical data and put it all in an algorithm, which gives them a score, a Stockholm3 score. If the Stockholm3 score is significant, then they do an MRI.
Sure.
If the MRI is, there's a grading scale of MRIs, and a PI-RADS score of an MRI of 1 or 2 is not indicative of clinically significant cancer. So those people are followed. They're usually not biopsied. If it's 3, then they refer to a urologist for a biopsy. And the biopsies nowadays are done, a lot of people are going to transperineal biopsies, which reduces the risk of infection after a biopsy. If it's a PI-RADS score of 4 or 5, that means there's a lesion there that they do systematic biopsies on. And that dramatically has improved detection of clinically significant prostate cancer and has eliminated the risk of being diagnosed with clinically insignificant prostate cancer. So, and unfortunately, in this country, we have not kept up with that kind of evolution. And so that's why this discrepancy, this 2 camps exist.
Sure. From the perspective of the U.S. Preventative Services Task Force, what are some of their arguments that initially gave them a D recommendation when it comes to prostate screening and now a C? What were some arguments in their favor?
Well, they had legitimate arguments, and the arguments were that we were diagnosing too many indolent, unimportant, clinically insignificant cancers and operating on these people or radiating them. And that was causing significant morbidity because back then, a lot of patients were impotent after surgery. A lot of patients were incontinent after surgery. I can tell you that my patients weren't impotent. A lot of them weren't impotent or incontinent because we're diagnosing them early. If you diagnose a person early, you can do nerve-sparing prostatectomies, and that spares their potency. I would say that fewer than 20% of my patients were incontinent, and of those, only a handful, less than 2%, were dramatically incontinent that would require an operation to fix their incontinence. Be that as it may, with the development of robotic prostatectomies, there have been improvements, significant improvements in the incidence of impotence or incontinence. But the U.S. Preventive Task Force was right in saying that urologists were taking way too many prostates out that didn't need to be taken out, causing too much more morbidity from the surgery or for radiation. And therefore, they're not recommending screening. Now, their definition of screening was screening everybody, no matter what their age, no matter what their risk factors were, screening everybody. Well, they recommended not even doing a PSA test or a rectal exam on anybody over 70. And I think that recommendation still holds today, which is, in my opinion, wrong. But that's why they had their level D recommendation, and then that was modified to level C in 2018.
Given the advancements in technology for screening, like you mentioned, MRI and some of these other diagnostic advancements, do you anticipate the U.S. Preventative Services Task Force to revisit the recommendations in the foreseeable future?
I would hope so. I think that if you look at the AUA guideline on early detection, which was published in April, I believe, of this year, since that guideline is very different than what the U.S. Preventive Task Force is currently recommending. Unfortunately, most primary care organizations, the family medicine people and the AMA, they're still locked into this level C U.S. Preventive Task Force recommendation. I can tell you that if you look at the document that the U.S. Preventive Task Force printed, there's many, many flaws. The U.S. Preventive Task Force uses 3 studies to base the recommendation on it: the PLOC study, which is in the United States, and then the European study, and then the Gothenburg study. And those studies are largely flawed and misinterpreted by the U.S. Preventive Task Force. And I was actually in the room at the AUA meeting in 2012 when they presented this recommendation. There was a panel of each author of each study, and a panel composed of a statistician from the University of Washington and about 1,000 urologists in the room. They presented the study, and at the end of the presentation, they asked for a show of hands. Does anybody in this room support the study? Not one hand was raised. And then the statistician got up and basically said, "You've misinterpreted these studies." And every author of the study actually got up and said, "We don't agree with this interpretation of the study. We don't agree with your recommendation. It's wrong." And there are many reasons for, if you go, there's lots of stuff in the literature about why the U.S. Preventive Task Force, or how the U.S. Preventive Task Force misinterpreted the data from these studies.
Well, let me ask from a patient standpoint. So obviously conflicting guidelines, and someone listening to you on this podcast, what are some of the questions patients should ask their primary care physicians about when it comes to that issue of prostate cancer screening?
Well, it depends on their age. Okay. If a 40-year-old comes to me and says, "Should I have a PSA?" I would say, "Yeah, I think you should." And they'll say, "Well, what if it's normal?" Well, I would tell them there's no such thing as normal. There's risk associated with every PSA, and your risk, being 40 years old, of having a PSA would be whether or not it's greater than 1.5. If it's greater than 1.5, then you're at risk. You have a 60% chance of having clinically significant prostate cancer for the rest of your life. And if it's greater than 1.5, I would probably get an MRI on you, which is no risk at all. And if the MRI is positive, that is PI-RADS of 3, 4, or 5, I would refer you to a urologist for consideration of a biopsy or other tests that would enhance your risk. And I would say those other tests are simple. They're blood tests, urine tests, and that's all they are. They're simple. It's a simple blood test or a simple urine test, which will really enable me to tell you whether or not your risk is increased or what it may be by just having a simple PSA or decreased. And it may be that your risk is decreased and you won't need anything except to be followed.
Sure.
And if you're followed, then the actual benefits of having the PSA test now, even if it's negative, are increased because, we're going to know whether or not you're going to have cancer sooner than if we didn't do the test at all. So that's the way I would have that conversation.
We're talking to Stephen Lieberman. He's a urologist, and his Kevin MD article is titled, "Is a PSA Test Right for Me? A Urologist Answers." Stephen, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
Okay. No such thing as a normal or abnormal PSA. Everybody has an individual risk of having clinically significant prostate cancer, and that risk can be really enhanced and further defined by lots of new diagnostic capabilities, including MRI, urine, and blood tests, like Stockholm3, like the 4K test. Early detection of clinically significant prostate cancer is definitely positive and definitely dramatically reduces the incidence and prevalence of advanced and metastatic disease. The current strategies that we're using do not increase the detection of clinically insignificant or indolent disease, nor do they increase the number of unnecessary biopsies that are done. In fact, we're seeing a decreased number of biopsies. The risk of early detection strategies have significantly been reduced by the introduction of MRI, and the risk of biopsies have been reduced by using transperineal biopsies. Risk assessment can be further enhanced by all these tests we've talked about: percent-free PSA, velocity, density, iso-PSA, urine tests, PCA3, ExoDx is a good new urine test, Stockholm3, 4K scores, genetic markers are used when people that have a family history. So there's lots of things that we have in our armamentarium to reduce your risk of having something done to you unnecessarily, whether it be a biopsy, surgery, radiation, and will greatly increase your ability to avoid metastatic or advanced disease. And if you do have metastatic disease, you're subject to increased risks from treatment of that metastatic disease because being on Lupron for the rest of your life is not a picnic. And having radiation for pathologic metastasis, bone metastasis, is not any fun either. And having a fracture from a pathologic bone fracture is not great. And dying from prostate cancer is pretty much, if you're screened or if you're detected early, is practically eliminated. I mean, if you remove a locally confined prostate cancer, clinically significant or not, the cure rate is 95%. So if you're 40 and asking whether or not you should have a PSA, my answer is yes, you should. If you're 75 and have other medical comorbidities, you don't need to have a PSA. And it's all based on whether or not you've had a PSA before and, all that stuff. But thank you for having me on. I really appreciate the opportunity.
Sure, Stephen. Thank you so much for sharing your time and insight. And thanks again for coming on the show.